Okay, we're going to go with one video for COPD because you're going to have your hands full with cirrhosis here in a bit. Thanks a lot for COPD Foundation for supplying this information. COPD stands for chronic, as in long-term, obstructive, meaning it breaks apart the airway and has a hard time air moving. Pulmonary with lungs disease, chronic obstructive pulmonary disease. So we have bronchioles that branch off into bronchi that go into the trachea and the airway that branches off into bronchi that have bronchioles that branch off into alveolar ducts and then into alveoli, millions of them, obviously grossly enlarged. But when we draw the lungs here, right? So in the lungs, what's happening is over long-term exposure to cigarette smoke, so tobacco smoke really is the largest by far, 90 to 95%. Others include exposure to tobacco smoke, to air pollution, as well as there's a genetic factor as well, very, very minor amount. But most cigarette smoking, as subjected to that smoke, it does two things. Long-term chronic obstructive pulmonary disease is made up of two diseases together, and that is emphysema and chronic bronchitis. So these two diseases together. So chronic bronchitis has to do with the bronchi and the bronchioles being chronically inflamed. Chronic mucus production really keeps the air from moving freely back and forth between the air and really makes breathing out difficult. And then emphysema is air trapping in the alveoli. So the alveoli walls are destroyed and it traps air inside of there. And that old air kind of has a hard time leaving, making breathing out very, very difficult, making it feeling difficult, like you can't get a very large breath. So the alveoli branch up actually, and they go way up into here. And oftentimes, because the smoke rises, these are affected first, and it takes a long, long time. This is a progressive disease over years and years of this exposure before it finally trails down into here and all of the lung is affected. Signs and symptoms: patient might present with shortness of breath and dyspnea, laborious breathing, difficulty breathing laying down, orthopnea. Signs: you may have a low SpO2, low pulse ox. Right? You may see laborious breathing and dyspnea. You might hear wheezing. There might be a chronic cough. There might be hemoptysis, which is coughing up blood, and cyanosis as well. I'm running out of room here, but cyanosis, bluing of the skin, lack of oxygen getting there. Having to do with a diagnosis, there's going to be a health history and an exam from the physician, right? Going to listen to the lungs, talk to them about their smoking, talk to them about exposure to other pathogens, genetic history. Going to look at your vital signs, make sure that they're accurate. They might order a chest x-ray. Before that, the very first thing, they're going to ask for a PFT. That's you doing a spirometry test. And on the flow chart, you're going to ask them to take the maximum inhalation out and blow out as fast as they can. You may see a good size of a flow, but then as breathing is gone out, as volume continues, the flow rate goes down significantly and it creates this concave curve. That shows obstruction, which is indicative of asthma or COPD or another obstructive disease like CF. But that's one step. Then they'll take a look at a chest x-ray to take a look, maybe do a CT scan for emphysema, and they may do ABGs, which stands for arterial blood gases, and they want to take a look to see exchange of oxygen, carbon dioxide. If these are inhibited, there might be abnormal levels. Treatment: bronchodilators, but this may or may not have too much of an effect. There may have to be on oxygen therapy, and they may want to be put on steroids to help quell the chronic inflammation of bronchitis. They may want to try and stop that inflammation from occurring. There may be surgery to remove parts of the lung. There's studies that show, or there's bold research, right, that show removing part of this damaged lung can actually increase lung capacity and that feeling of getting better breaths. But COPD cannot really be improved. it can only be slowed, and to help the patient feel comfortable as they progress. The real prevention is to quit smoking if you do, and to help promote and encourage good habits in those we love, as well as encourage those who would like to quit smoking to do so.